Okay, today we are diving into something absolutely wild. We're unpacking a truly fascinating cascade of human physiology, a condition known as Nelson syndrome. Our bodies are just these incredibly complex machines, meticulously balanced by intricate feedback loops. But what happens when we medically intervene and accidentally sever one of those critical loops? Today, we're going to map out the exact domino effect of this condition, and we'll be using some really clear visual steps to understand how a seemingly successful surgery can inadvertently set off a massive biological chain reaction. So, think about this for a second. What happens when removing a gland unleashes a totally hidden tumor? I mean, it sounds like a medical thriller, doesn't it? In medicine, treatments are obviously designed to cure or manage a specific problem. But in the unique scenario of Nelson syndrome, a necessary surgical procedure actually acts as the catalyst, the spark, that awakens a completely different, silent threat just lurking elsewhere in the body. It is literally a perfect storm of anatomy and endocrinology. We're pulling from some fantastic source material today from MedAce on high-yield endocrinology, and it brilliantly illustrates why we rely so much on structured medical knowledge. To really master this stuff, we have to connect the dots between completely different organs. So we are going to break down this high-yield topic step by step to make sure you fully grasp the mechanics of this syndrome. Right, let's jump into Section 1, the setup. What exactly is Nelson syndrome? Well, Nelson syndrome actually has a second name that kind of gives the whole game away: post-adrenalectomy syndrome. This isn't a disease that just happens spontaneously out of nowhere, right? It is a direct consequence, a post-event, of a very specific medical intervention. The name itself tells us the trigger. It happens after an adrenalectomy, which is the surgical removal of the adrenal glands. But here's the catch. For Nelson syndrome to actually occur, two distinct elements absolutely must coexist. On one side, you have the trigger, a bilateral adrenalectomy, but that surgery alone doesn't cause Nelson syndrome. On the other side, you have the hidden danger, a completely undiscovered pituitary adenoma just waiting in the dark to be unleashed. The physician doesn't know it's there. The patient has no idea it's there. It's totally silent. Okay, moving on to Section 2, the cascade, pathophysiology. Let's follow this beautiful, but honestly pretty dangerous cascade of the broken feedback loop. Step 1. The bilateral adrenalectomy happens. The adrenal glands are removed. Step 2. Because those glands are gone, there is suddenly absolutely no endogenous cortisol being produced. And without cortisol, a critical brake system in the body just fails. You see, cortisol normally travels back up to the brain to tell the hypothalamus, hey, we have enough hormone down here, you can stop stimulating us. That's negative feedback. But now, zero negative feedback. Step 3. The hypothalamus totally panics. It thinks the body is starving for cortisol, so it drastically ramps up its production of CRH, or corticotropin-releasing hormone. Step 4. This massive surge of CRH bombards the pituitary gland. And remember that hidden, undiscovered tumor we just talked about? It happens to be an ACTH-secreting adenoma. Suddenly, it's being force-fed massive amounts of stimulatory CRH. With the brakes completely off, this tumor undergoes rapid, uncontrolled enlargement. Step 5. As the tumor grows like crazy, it dramatically increases the secretion of two things, ACTH and MSH. The dominoes have officially fallen. Which brings us to Section 3, the fallout, recognizing clinical features. Now, we can neatly divide the symptoms a patient experiences into two distinct categories. First, we have the mass effect. This is essentially just a physics problem. The pituitary adenoma is physically growing larger and larger inside the very confined, bony space of the skull. This physical pressure causes severe headaches and a highly specific vision issue called bitemporal hemianopia. Second, we have the hormonal effect. Remember from our cascade that the tumor is aggressively pumping out hormones, specifically MSH, or melanocyte-stimulating hormone. This massive surge in MSH chemically stimulates the pigment-producing cells in the skin, which leads to intense cutaneous hyperpigmentation, a really distinct, very noticeable darkening of the skin. Let's actually isolate that vision issue, bitemporal hemianopia, for just a second. So, as that pituitary tumor enlarges, it physically pushes right up against the optic chiasm. This mass effect basically acts like a roadblock on the optic nerves, resulting in the loss of outer peripheral vision on both sides. The patient develops tunnel vision, and it's directly caused by the anatomical swelling of that unreached tumor. All right, Section 4, the fix, diagnosis and treatment. So how do we catch it? The diagnosis is essentially just confirming exactly what we mapped out in our pathophysiology steps. We draw some blood, and tests will consistently show dramatically high levels of beta MSH and high levels of ACTH, literally the exact hormonal surge we predicted. But blood tests aren't enough on their own, right? We need to see the culprit. To definitively confirm the diagnosis and visualize the problem, an MRI of the brain is absolutely required. This imaging will clearly reveal that dangerously enlarged pituitary adenoma. Once we've located it, the tumor driving all this chaos has got to go. The primary treatment is something called a transsphenoidal resection. By going minimally invasively right through the nasal cavity and the sphenoid sinus, surgeons can execute a really precise, definitive strike to remove the source of the hormonal storm.
Now, while transsphenoidal resection is the frontline treatment, it's plan A, there is a backup plan. Surgery is always step one. However, if the tumor has grown in a tricky way that makes complete removal impossible without, damaging surrounding brain tissue, there might be some tumor residues left behind. In those specific cases, pituitary radiation therapy is utilized as a secondary treatment to target and destroy any of those remaining problematic cells.
Which brings us to the core lesson of this entire explainer. The human body is definitely not just a collection of isolated parts. It is a brilliantly synchronized network that is entirely dependent on negative feedback loops. Nelson syndrome is pretty much the ultimate cautionary tale of what happens when one of those loops breaks. Removing one gland, the adrenals, can inadvertently unleash a hidden tumor in another, the pituitary. It's a stark reminder that every action in our biological system can have profound unintended consequences if we don't fully respect the body's internal balancing act. And that wraps it up. Thank you so much for joining me to visually unpack this fascinating physiological domino effect. If you found this breakdown helpful and you really appreciate using a lot of graphics to clearly explain complex medical concepts, please make sure to subscribe to the Mid-Medicine channel. We are totally dedicated to bringing you clear, visually driven medical explainers just like this one. Keep learning, keep questioning, and I will see you in the next explainer.